was a very important subject. It may be the subject of future, what is called opioid-free anesthesia and analgesia from bariatric surgery to regular practice. Really is my beautiful city, and hope one day to make a conference to invite all of you to come to Russell Park. Really, I don't have any conflict of interest about this presentation, but I would like to thank you a lot for wasting your time, about half an hour. But I hope, inshallah, to get some benefits, to be blessed from Allah. And I will try to make my presentation as long as possible to cover the subject, and as short as possible, not to get bored to fall asleep. So what is the objective of this learning objective of this presentation? I will speak a little about the history and reason behind the concept of opioid-free anesthesia and the history of opioids. I will discuss some opiate-sparing technique and the modalities and how to start challenging the debate about opioid-free anesthesia and the evidence behind opioid-free anesthesia, and at the end, the home message. The problem there is, what happened? Screen stop? Yeah, that's okay. So when just to speak about pain and definition of pain, most of the time it gives more confusion than declaration about the definition. When you said the unpleasant sensory and the emotional experience associated with actual and potential tissue damage, or describe in terms of such damage, it become more confusion. But to be simplified, that the pain have a what's called sensory affection and some other emotional effect about the pain. And there is a new definition, or resembling, is that associated? He put on somewhere more to the definition and become more confused. But in simple way, pain is a bad sensation affecting the body and the patient heart. So I think you can agree with me that we can change the style now or before, and to agree with me that pain is subjective, different from one to one, and being underestimated most of the time. And most of people in recovery, about 40% to 80%, have moderate to severe pain. And also the pain undertreated all the time because it needs a reaction from the physician. The problem with pain is that we don't have a measurement like a blood pressure, like a saturation. So we don't have a right measure for pain. And I think you agree with me, no pain and no gain. This is only in life, but with pain, if you have a pain, you will not get anything. And you agree with me also at the end, remember Krebs cycle in our practice. So the opioid started to use 300 BC from Babavir seminiferum, started from India. Take this white stuff by scratching by a knife. In 1806, morphine was purified from this Babavir seminiferum. After that come the semi-synthetic and synthetic medication. In 1940s, mipridine, methadone, and ibuprofen. In 1955, fentanyl from Johnson, because the original, this is the Dr. Johnson and make a company for that. And 1969, Lovenstein, he make a concept of stress-free anesthesia with only higher dose of opioid only. In 1982 and 1984, fentanyl, sofentanil, are carfentanil is a drug not used in clinical practice, but is a very potent drug, can be used for hunting of the elephant and big animals. In 1994, remifentanil started to use as a TIVA, was called switch-on, switch-off anesthesia. The interesting history about the pharaonic mummy, they found this mummy contained some nicotine and some cocaine. So there was this drug during this time. And in 1907, this man was selling a mummy. Mummy was sold like this in the street. And in 1917, this picture from Egypt, that a very good business to cultivate Babavir seminiferum and to sit it outside until become after that illegal. And because our practice is not one fit all, not all type of anesthesia can fit people. And we have many routes for the same target. You can go for this way as this way. The way you master is the most important than to put what's called opioid-free or opioid anesthesia. But the most important thing is the paramount for us is the safety. Safety is more important than anything else, to do technique or not. And you must have a second plan because you can change your plan at any time. So whatever you use a general anesthesia or regional anesthesia, or mix it between general and the regional anesthesia, or just by different degree, general mainly, and some regionals mainly, and some anesthesia, opioid-free anesthesia or multimodal analgesia. So the goal of analgesia to improve perioperative outcome and post-operative pain and related complications associated with pain, many complications from thrombotic manifestation, discomfort, nausea, and vomiting, and a very bad quality of life, or to prevent peripheral and central sensitization, to prevent what's called persistent or chronic post-operative pain, which can stay for many years after the operation, and to decrease the drug-seeking behavior. And it's a very important issue, because usually I work in pain clinic, and most of the patients become addict from the hospital. You know, the percentage of people which get addict from the hospital, in American survey and audit, it found about 4 to 6%, about 5% from the people coming to the operation and go outside by become a drug seeker or an addict. And usually are the reason behind that. If you don't put in your mind that this patient can be addict because I use a high dose of narcotics and over management for his pain. And the problem all the time, this patient is not a number. It is a human being, have a family, have a work, have everything. And he can lose all this stuff because you just give him overdose of narcotic or just over-treating the patient. So now our role not just started in mainly on OR. I think all people like me, when I started my career, just was concerned about patient first time to see him on the table. Now there is a lot of assessment into OR management and also OR management. And most important for us is that the patient recover in a smooth way and without pain, to be happy in recovery. So different mechanism of anti-nociception. What we know, what we don't know about pain is like a tip of iceberg. Is a very little, you know, very little about the pain. And from the pathway for pain or pain fibers have a central cholinergic system, spinal dynorphin, descending facilitation and descending inhibition, genetic mechanism of pain, and decrease the uptake, enhanced nociceptor response, many mechanisms. And you know that when you just get a trauma, this is make a sensitization for peripheral nerve ending and make what's called an action potential to send the wave to a spinal cord, and the spinal cord decassate to go to 2 or 3 level above or below, and just go into the brain. And the brain is the central control of pain. What the brain did, send what's called an inhibitory pathway to decrease the pain and to modulate the pain. But sometimes the system become very crazy, instead to decrease the pain, increasing the pain. And there is many medication working in every step. So the concept of multimodal analgesia came from using many drugs to block different area to get a better result with a little dose and not on one drug. So you know that is a very complicated thing. Many things can just work in pain management, from muscle, macrophages, and allogenic soap, bradykinin, calcium peptide, and even pH and potassium. Many things working. And because of that, you know, different drug working in different receptor can give you a good result. And this is the same like before. And you know that, as I told you, the brain is the control, how control of pain. So if you are lucky and don't have a brain, you don't have pain because you don't lose the control. So what about the epidemiology for crisis of this opioids? You know, starting from 1990 until 2009, and this create about 15 million American from people addicts, and about 75 or more started in the hospital. And I think in our countries here, or just in Egypt, I think it will be 90% to start it from the hospital. So you can remember 55 billion in health and social cost of opioid abuse. You imagine the number, $55 billion. $20 billion in hospital care for opioid poisoning. If the patient get a high dose or get a problem with the narcotics, it's $20 billion per year. And 2.5 million have severe opioid use disorder. And this is those people usually going to the grave in car accident or just an overdose. And again, every day in America, you have 650,000 opioid prescription per day. And you can know that about 4,000 patients started anew as people who are taking and prescribed medication for narcotics. And about 80 person died per day, 80 per day in America from opioid overdose daily. And this number is very big number. It's more than the number of RTA or suicide tendency. So the crisis increased. Because of that, in March, last March, about 3 months ago, the FDA approved Narcan, an opioid antidote for over-the-counter use amide overdose for epidemic. You can just buy from anywhere, from even supermarket. And also, it found in the school, because many kids in the school just a drug addict, and you can use this as to drug to helping him about this addiction. So the predominant treatment has consequences. We started as opioid, as the main drug. We can't make anesthesia without opioids. So pain, we need opioid, and opioid bring prolong the recovery, and sometimes become an opioid dependence and addiction, just to go into chronic pain, opioid side effect, and inadequate treatment of pain. This is like a vicious circle, you must cut it. So drug seeker is a very big problem. And as I told you, it is a major, and it can happen in major and minor surgery. Don't relate it to the surgery. It may be related for other things. It may be related to genetics, over saying, I know I have a patient, he come to my clinic, and I found the patient taking tramadol, Lyrica, methadone at the same time. And I look for the file. I don't find anything deserving this medication. So I told him, I can't give you medication. The man cried, and they tell me that 2 years ago, I make a carpal tunnel release for surgery, and you started, and your colleague to me addict. So I lost my work, I lost my family, I lost everything because of you. You just remember that, because I'm working in pain clinic, I see a lot of patients like this. So the rate of new opioid abuse from OR, coming from OR, is 60%, whatever the operation is big or small. This is the pyramids, and this man riding the camel is not me. So just to go to the pyramids. So the pyramids now is inverted, sorry. It inverted. Before, the opioid was the base of the pyramids, and we can use many, many other drugs, but now the opioid becomes the top of the pyramids. When I speak about opioid-free anesthesia, I don't mean to be totally free, but at least less anesthesia. Because in some cases you can do it, in some cases it's contraindicated to do it. So the pyramids change from the base to be narcotic-based anesthesia to be narcotic-free anesthesia or less anesthesia. So we are lucky in these days, because I think the old people like me or like other colleagues, when we started our career, we don't have all this option. We don't have local anesthesia all the time. We don't have ketamine. We don't have magnesium. We don't know a lot about the other medication like clonidine, dexamethasone, but we know a lot about opioid. Now, the concept of multimodal analgesia is accepted by the anesthesia community. But all the time, don't forget, because this is a very helpful to treat your pain by other methods away from medication, like behavioral, environmental, physical, cognitive, interventional, and movement, and even psychological support. So what is the best way to avoid opioid anesthesia and analgesia? What is the best way? I think the answer not to do operation, but this is a stupid answer, because you must do operations. So what we don't know about pain now, we don't, as I told you, the pain, what we know about the pain like a tip of iceberg. This question, I don't find a clear answer for this question. Why some people respond to some medication more than others? Why the same patient, different patient have the same pain, and I give this one medication it help and the other one not helping? And why the same pain response good in one patient and not in the other? Monitoring or nociception. We don't have a real monitoring for nociception. We have a monitoring for heart rate, for saturation, for everything. But for nociception, there is attempts that to measure by IBOBLs or EEG, but this is not a real to measure pain. Which is more better, narcotic-free anesthesia or narcotic-based anesthesia? Are opioid mandatory during anesthesia? Yes or no? We don't know. Reason behind using opioid. So in this paper, I bring it from Dr. Yasser Reda. This is published 2019, and they speak about opioids are definitely absolutely essential, but they are certainly very useful in producing drug-induced reversible coma anesthesia. But this is not controlling completely the nociception, and using the opioid more conservatively. This is a recommendation of this paper, because sometimes not helping. Another paper I bring you also from Yasser Reda about meta-analysis for pain, and about 27 studies, big number of people, and the recommendation came: patients are treated with high intraoperative doses of opioid had a higher post-operative pain intensity and higher post-operative morphine use and after 24 hours. And this happened was 1 hour recovery, because I'm head of recovery. I see this patient, and I see patient a very big amount of complication because of bariatric surgery. So the multimodal anesthesia, zero and practice, and most of people agree with that. Agree with multimodal analgesia, multiple drug, different and multiple receptors, and in a small dose, and give a better result. And in anesthesiology 2019 annual meeting, just to give a clue about eliminating opioid from anesthesia, decrease post-operative nausea and vomiting. This came 2017. Again, incidence of iatrogenic opioid dependence or abuse in patients with pain who were exposed to opioid analgesic therapy, systemic review and meta-analysis, and all the many study, and they found that this, like in previous study, about 60%, is about 4.7% for people going to OR coming as a drug seeker or addicts. So when I ask you what is the maximum dose of narcotics, so the answer is the sky. No upper limits. Some patient can tolerate 10 milligram, other patient can tolerate 100 milligram. So the what's called the higher dose to see the effect or to see the side effect. You know, this is a very important to see the effect of medication or side effect to be a barrier to stop narcotic after that. So in the opioid epidemic, as I told you, from 1990 until 2009, about 15 million .6 person get an addict, because every single easy. Even I read a book about 20 years ago. They speak about the narcotics for headache is the best drug because it don't make a renal failure like anaesthesia and this medication. And we consider the pain is a fifth vital sign. I must control this. So sometimes we are aggressive to give medication. The patient don't need it. So in 1997 to 2007, it's 10 years. Use of opioid increased about 149%. Oxycodone increased about 688%. We're going very fast. And opioid epidemic was born as a consequence of these issues. And deaths from opioid more than the deaths from suicide and road traffic accident. Because of that, you know, the American government just started to put a strategy to treat the people. One of the strategy to make an opioid-free anesthesia. And the idea started in Australia and New Zealand in a bariatric patient and spread it all over the world, even for other type of surgery. And you must remember that addiction is a disease by itself. So in America, 75% of opioid addiction started within prescription from the hospital, not from black market. So the strong opioid usually incriminated by addiction more than a weak opioid. I mean by strong, that have a higher affinity to a opioid receptor or other receptor. But don't forget that many drugs can make an addiction. And sometimes use another thing. People created some medication to make an addiction. An addiction can happen in many stuff like coffee or just a computer. And all this type of addiction as the end sending to the grave by overdose, car accident, you know, stealing money. I have a patient here. He needed money for drugs and his mom refusing to give him. And he stabbed his mom and his dad and his brother. Alhamdulillah, they come saved, but you can imagine, you know. So because of easiness to give a prescription, taking the effect of June 27, it's not coming now. 2023, all drug enforcement administration must be registered practitioner or need a testing, need a provocation or to attorney to be tested before the prescription given. Because it's even closed many clinic in America because people give a lot of medication for some people, whatever he deserve or not, but just try to treat the problem. So what about opioid-free anesthesia after this long introduction? Can we make a hypnosis? Sorry. Hypnosis, sympatholysis, amnesia, hemodynamic stability and mobility and neuromuscular blockade? Yes, we can, because now we are in the era of luxuriously big amount of medication can be used. And this medication, as I told you, is an multimodal analgesia as a proved concept between physician like and given non-pharmacological opioid, regional anesthesia, acetaminophen, non-steroidal inflammatory, magnesium, ketamine, many other drugs can be used. So in this study published in 2008, about 12,000 surgical inpatient noted a correlation between persistent preoperative opioid use following surgery and mortality. The more you give a narcotic, the more you have a mortality. I don't speak about this a wrong practice or what's called a right practice, because if you make a wrong practice and they bring a good outcome, it's still wrong. So what is this picture? Anyone know? This is in what the area is called the Lisan or the Time in Russell Bar, and this is a map of the Nile, 6,200 kilometers until to be in the sea. This is the area for the sea, and this young boy sitting here is my grandson. So the era started by, inspired by obesity, because for these people, I can't have a obstructive sleep apnea, he can't sleep flat, and they have many problems. So if I give him narcotics, I can kill him. And I see that in our recovery. In our recovery, unfortunately, some of the old-fashioned people still doing that high-dose narcotic, they don't give multimodal analgesia. So and this in a review article is called Opioid-Free Anesthesia as a Future of Pain Management. And now we are in an era of regional anesthesia. We can make regional anesthesia anywhere. Every part can make an regional anesthesia for it. Even if it's not analgesia, anesthesia, it will be analgesia to decrease the narcotic requirement. So we consider that the recommendation, we're doing a real paradigm shift from the narcotic-based anesthesia. And the Cleveland Clinic have ahead, it's changing its approach, opioid-free surgery, alternative pain management therapy, new prescription guideline. Again, in anesthesia, analgesia, anesthesia, and analgesia. Opioid-free anesthesia in the era of enhanced recovery after surgery and the surgical home implication for post-operative outcome, population health. So they said also that in eras, use of regional anesthesia, use of other medication, avoid the opioids, you can discharge the patient early. And first thing about the patient treatment, not to harm by other medication. Opioid-free anesthesia and colorectal surgery, they found that the more dose of opioids, the more recurrence of the tumor and more worse outcome. So whenever you use an other drug, it can help the patient to increase the immunity because narcotic usually immunosuppressive. This is a very interesting picture. They found that fentanyl infusion after 3 to 4 hours, it lost the analgesic effect and make a tolerance. And many patients, if you give them high dose for a long time, it can what's called making narcotic-induced hyperalgesia, not even decrease the pain, increasing the pain. Again, opioid-free anesthesia and opioid-based anesthesia, strong evidence that opioid-free anesthesia, opioid-induced anesthesia, not reducing the post-operative pain, or opioid-based anesthesia, should use more post-operative nausea and vomiting. And again, the opioid-free anesthesia is recommended. Many people and another paper. And you can tell me that it can increase awareness. But really, in a prospective randomized controlled blind trial, they found opioid-free anesthesia, the incidence of sedation and amnesia is very good, as there is no recall during anesthesia. So again, this paper came from Pakistan, and some people from Turkey. Opioid-free anesthesia and laparoscopic cystectomy and work good and decrease the number of narcotics and drug-seeking behavior. Another paper also from Korea, everywhere, from Saudi Arabia, non-opioid versus opioid-based anesthesia technique for bariatric surgery. It starts for bariatric surgery and become now for every patient. Even in cardiac surgery, rectospinal plane blocking cardiac thoracic surgery to provide safe and effective analgesia, opioid-free, and they said it can start to make a paradigm shift for the management of fast tracking of cardiac surgery. Opioid-free anesthesia for laparoscopic surgery is a paper from Egypt, and it said at least the opioid-free anesthesia is not inferior to opioid-based anesthesia. But all the time you found that debate, there is no black and white in medicine. So you know that sorry, it is not better, and some people just go against the flow. And like this paper, opioid-free anesthesia, benefit, risk, and balance, systemic review and meta-analysis for randomized control study. They said no great benefit were observed with opioid-free anesthesia in the term of pain and opioid use after surgery. Benefit opioid-free anesthesia used to observe the respective reduction, possible and vomiting, but also we need more data, more study about this. What is the advantage of using opioid in anesthesia? To blunt neuroendocrinal activity, hemodynamic stability, and give an analgesia to decrease cardiac load and blunt catecholamine response, and decrease stress response, decrease need for hypnotic analgesia. For example, lisprofol. Goal of avoiding opioid. Why avoid opioid all the time? Because the side effects that affect urinary retention and very big incidence of side effect. Tolerance and addiction, dizziness, excessive somnolence, opioid-induced hyperalgesia, worse outcome in oncology and addiction is a very important point, this last point. And avoid opioid in the postoperative period, opioid-free anesthesia. Usually it is a bariatric in obese patient started paradigm shift. And this is a scientific revolution of anesthesia, excluding or severely limiting opioid side effect. So the other goal to prevent respiratory depression, central muscle rigidity, pharyngeal muscle weakness, especially in obese people, and obstructive sleep apnea, obstructed breathing, negative inotropy, nausea and vomiting, ileus, and constipation. So the bariatric started, and many study about it, starting in New Zealand and Australia. And they give a bariatric anesthesia worldwide have accumulated data using an opioid-free anesthesia that could be useful in many clinical scenarios. And I think this Mona Lisa after marriage become like this. So one of the scientists, great people using an opioid-free anesthesia from Australia, he said, given the decline rates of mortality and morbidity following common elective procedure, new persistent opioid use represent an important and recognized complication for perioperative care. So opioid-free anesthesia for bariatric surgery started by Miller Group and the MICA protocol to give dexmedetomidine infusion, ketamine infusion, lidocaine infusion, propofol, and rocuronium, or ganatricurium with a short-acting muscle laxant, which will come in the future, and dysfluoride. Sometimes it is an other protocol give a sevoflurane and intervention magnesium. Can we make what's called the SIBL? This is picture from a bariatric surgery, and it's no narcotic at all for this monitor. And there is a hypnosis, symbiosis, amnesia, hemodynamic stability, muscular blockade, and analgesia, and no increased incidence of awareness. Again, indication of opioid-free anesthesia, there is usually a common case to be used. There is a gray zone relative, and this is a contraindication. So opioid-free anesthesia can be used for obese patient with obstructive sleep apnea, started like this. Pulmonary disease like asthma, COPD, acute and chronic opioid addiction, previous hyperalgesia problem, in some diseases like complex pain syndrome because narcotics increase pain, chronic fatigue syndrome and fibromyalgia because don't have an effect on this fibromyalgia, oncological surgery, and inflammatory disease. But the most important thing here about, that when you speak about narcotics, when you speak about addicted people, if the indication here, the indication will be mandatory, because if you don't give him regional anesthesia and other modalities, the patient would need a very high dose. He needs a basic dose for the day and more doses for the pain. I have a patient here to take 120 milligram morphine and still screaming as an addict. And when he make him unblock, the patient gets respiratory depression. Also, it is a very big part of enhanced recovery all the time. Avoid long-acting opioid analgesia for fast tracking. Also, traditional perioperative care versus ERAS. So all people speaking about ERAS. ERAS just can give a high quality of life. Discharging a patient early, cost benefit more better. So opioid-based anesthesia is one of the worst things about ERAS. Again, there is when I speak to you now, I try to convince you about idea, but I know some people still resisting. And this is a current barrier to opioid-free anesthesia practice. First thing, there is a question to ask ourselves, why resistant to change? First thing, because cost of opioid-free anesthesia may be more higher than the opioid-based anesthesia. Evidence-based practice, we need an evidence-based, more study, because we use narcotics more than 100 years. So we need just to be a good evidence to use an opioid-free anesthesia. Lack of training. So some people tell me that I tried or I was the patient and I suffer a lot because I don't get narcotics, because who treating you don't have a training how to use it, the medication, how to master the medication, how to combination for the medication. So training is very important. Insufficient guidelines, we need guidelines and policy and procedure for everything. And usually it is dependent on evidence and limited data because it's a new era. The pitfall of opioid-free anesthesia, sometimes I tell you that I don't have good sample analysis by the narcotics, so I found tachycardia, hypertension. Or sometimes excessive sample analysis happen because I give high dose of inhalation anesthesia. So you need to control by ephedrine, clonidine, and theoretical risk about the awareness not having. And also in some medication like dexmedetomidine or clonidine, you can get a post-operative sedation with hypotension and bradycardia. So benefits of opioid-free anesthesia, first thing, to modulate the inflammatory and immune-mediated response away from narcotics. Narcotics, especially morphine, make an immune suppression and increase the incidence of recurrence. Multimodal pain strategy, which is accepted between the community of anesthesia and a part of enhanced recovery. And again, to give your receptor version if you need it after that, because whenever the opioid receptor occupied by narcotic, it need more dose and the effect become less and less. Also, one of the benefit to be less prone to overuse and misuse and abuse and addiction, because it can distracting the life of the patient. Prevent sensitization, tolerance, and hyperalgesia. This is multimodal, more better than narcotics, with narcotic-induced hyperalgesia very common. And decrease the incidence of chronic post-surgical pain. Again, early return of oncological treatment if you don't make narcotics, and it's proved by many study. Early hospital discharge to improve cost of control and the quality of life and the expense. Mitigate opioid-related adverse effect. You avoid abuse side effect, because abuse side effect you need more money, more hospitalization. Prevention of opioid related deaths. If you don't as an opioid or become a drug seeker, you can die at any time. Promote regional anesthesia practice because that's shape and give a very good response for pain, and mitigate opioid crisis. So be aware that increased risk of patient complication a lot. The patient, when I speak about the addict mandatory to use a multimodal, especially regional anesthesia. And this patient is a unique patient about they have an aspiration, compromised airway because all the time sedated, and have generalized edema from the drugs, venous thrombosis from injection, abscess lymphadenopathy, and immune suppression, hepatomegaly, and dysfunction, and hemodynamic instability. And this is not the time to treat the patient from addiction when coming to OR. To give him the same dose per day and give other multimodal analgesia. So not at a time for weaning the patient during operation. And regional anesthesia as a part, regional anesthesia now extended. Today I have an workshop about, I was in faculty workshop about percutaneous tracheostomy per day and use of regional anesthesia even for block. And it can be catheter bottled and to eliminate use of opioid, or just give liposomal bupropion, can stay for a long time. Local infiltration and many blocks can helping to, again, if you use an agonist antagonist, which was just addictive like buprenorphine or just digoxin, it can help to decrease the addictive power for narcotics, but still everything have a pro and cons. The contraindication is not, as I told you, this is not one fit all. Some contraindication for opioid-free anesthesia, like allergy to one of the drugs used, heart block and pre-existing bradycardia, and also in a stable patient like a shock or ischemic heart disease, and autonomic nervous syndrome with metabolic syndrome and diabetes. So as I give you some evidence about it, you know, I like this slide everywhere. According to our recent study, marriage is the main reason behind divorce. And this is a class evidence. But you must remember that as absence of evidence is not evidence for absence. Sometimes you have a very good evidence, but you need a time to prove that. You can't compare a drug or just a regimen working for 100 years with a regimen now working for 10 years. It needs a time. So it needs a more discussion. Because, you know, everything, if you don't master, you can get a risk. I believe was a shark. But to know now, there is many conferences about the opioid-free anesthesia and how to use the medication, and what is the protocol for different patients. Like this debate, it was in 2016, debate opioid-free anesthesia, which is a bloody debate, not finished at all. And rethinking all the time about opioid use. And this is another one, an American Society of Enhanced Recovery, narcotic-free anesthesia and narcotic-sparing analgesia. Can we avoid opioid? And another conference. And this is a website of the Society of Opioid-Free Anesthesia. If you wanted to go to see more details on the site, this is the site, Opioid-Free Anesthesia Society. This is a picture from the page. You can just go to read a lot about everything about opioid-free anesthesia. I know the time is squeezing, and sorry for delay in the beginning, because I know that your time is precious. And some of you doing like this for me to finish, voting me to finish, but this is my sweet conclusion. Opioid-free anesthesia is possible. Yes, it's possible. It is alternative for opioid anesthesia. Yes, it's an alternative. It's better for selective group of patients. It may be not fit all the patient, but at least major group of the patient can benefit from it. Might be better for most of the patient. As I told you, I don't speak really about complete for opioid-free anesthesia for every patient, because sometimes you need what's called opioid-less anesthesia. And it may be the future of anesthesia and this paradigm shift. Again, now we are lucky because we have an area for multiple choice. No medication is benign, all the medication is malignant. Pain is multimodal factorial challenge, so we need a multimodal analgesia. And remember, opioid epidemics and risk of the patient life. Understanding opioid and opioid-free anesthesia maybe reduce these epidemics. Multimodal analgesia help to avoid large dose of opioid. Hypnosis, analgesia, amnesia, symbiosis, and hemodynamic stability can achieve, and that's an issue from protocol in Australia. Analgesia adjuvant agent can be used postoperatively to maintain opioid-free anesthesia. Surgeon need to understand that pain affecting the patient for the rest of his life. Pain distracting with opioid overdose or seeking behavior, distracting the life of the people. Don't remember a people as a number. The human being will have a family. A study from independent unit worldwide are awaited. We wait for more study from different area around the world, and also we're searching for data and research, whatever in vitro or in vivo about these topics. And now remember that life does not get better by chance, it gets better by change. And I hope to convince you about this idea. At least if I don't convince you, I will confuse you. So thank you very much, and for any question.
دكتور ياسر، شكرا جزيلا لحضرتك يعني على المحاضرة ده. أنا مش هقول حاجة عشان شهادتي في حضرتك أكيد مجروحة يعني. هو احنا عندنا أول سؤال من محمد علي يسأل حضرتك على الدوز اوف فينتانيل. هو بيدي العيان he gives the patient 100 or 200 microgram maximum fentanyl for 1 or 2 hours operation. Is that a problem?
You know that it is not a big problem, because you know that it's different from area to area. When I was working in Saudi Arabia in Riyadh, the people very sensitive for narcotics. We give usually 1 mic per kg. I think it's called pharmacogenetics. But in here or in Egypt, at least the patient is a little, he need more dose. It will be 200. Usually this is a normal practice for most of the people, you know. And starting with fentanyl, and don't give morphine after we give other modalities for analgesia. So the fentanyl here just decrease the sympathetic response for intubation and make a balanced anesthesia more better, decrease the other medication. But usually we make a multimodal analgesia. It's a common practice. It can be done, and we have a debate for everything, but this is a practice of most of the people all over the world. It's not right, it's not wrong, but it's a practice.
I think from my past review of pharmacology, that when we use fentanyl as an anti-stress response during the intubation, it have a special time. When we have it as a potent analgesic before the skin incision, it will be 90 seconds before the skin incision. And as we tailored or personalized the indication of fentanyl according to the patient and why we use fentanyl for this patient, the timing and the dose will be taken.
This is, I agree with you, because the big operation is not like a small operation. The time, some operation is known to be more stressful than the other. But still, you can use an fentanyl. Don't have a problem with fentanyl. But what I'm speaking about, strong narcotics, which you can stay for a long time, like morphine, hydromorphone, oxymorphone, all this medication, you know. And some people use a fentanyl batch, which is totally wrong to use it for post-operative analgesia or analgesia.
Yes.
Yeah.
Now is the time to meet your great friend, Dr. Haitham Al-Jamil, Dr. Yasser. Your great friend, Dr. Haitham Al-Jamil.
Haitham the beautiful.
Yeah.
Thank you. You are the
Welcome,
marvelous.
Dr.
Yasser the marvelous, as usual. Really, I'm not surprised actually, because the way that you are going and streaming through this really hot topic is really amazing, very attractive and very interesting as well for everyone, and especially for me. I know that it's actually is a very debatable and very controversial. Personally, I think that going through the opioid-free anesthesia as a technique, or let's say as a belief, over the last 2 decades has gained more popularity. I would totally agree with you. But personally, I believe that you should be, first of all, a very good researcher, definitely like you, Dr. Yasser, and like Dr. Safa as well, if she's really supporting that. And also, you should have a very good way to control the pain by other manners, or like other maneuvers. Like I should be an expert in regional anesthesia. All this could considered as a comment. Okay, my personal question, after really expressing my deep gratitude for this invitation and my deep really impression for this fantastic exploration for this kind of really very interesting topic. Do you think that opioid-free anesthesia have a land, or have a space, or have enough room in cardiothoracic surgery? I know that you mentioned that actually clearly about the electrospinal block, and I'm using the electrospinal block as a way actually to control the pain, or let's say to reduce the intensity of the pain during the thoracic anesthesia, or like during tracheotomy. But still, I think there is some sort of limitation to use the opioid-free anesthesia. How you can convince me to use that in CABG or in valve surgery? I think you will show me the way. I mean, you show me the way how to do that, if you could, please. Thank you so much for that. Thank you, Dr. Safa, as well, for giving me this opportunity to ask this question. Thank you.
Thank you, Dr. Haitham. Thank you.
You know that before Dr. Haitham, what I remember, I'm not an cardiac anesthesia like you, but I remember our book 20, 30 years ago, it was speaking about 50 mic fentanyl per kg. So you give it for the patient, like a narcotic-based anesthesia, and he can stay 3 days until he recovers from this medication. But really, subconsciously, we did narcotic less anesthesia. I don't mean in this era to be totally free, but at least narcotic less anesthesia. And we do that subconsciously, because, you know, when you start our career, we have only 1 or 2 medications, that's it. Morphine, betadine, that's it. But now, subconsciously, we use a multimodal analgesia. The idea to decrease narcotics as possible as you can, because the drug seeking or all side effects related to the dose and the time, the high dose or prolonged use. So if you try to decrease it, I can tell you that in this time I can't stop it completely. Even for me, I use narcotics during induction, fentanyl, but most of the cases I don't use morphine, except in very rare cases for post-operatively, and most of people get a block. If not for anesthesia, it will be for analgesia, and the patient discharged, or I put a catheter for him. And very rare, some patients were very rare to give him an BCA. I don't like BCA, but sometimes we'll give it for. And as I told you, can't make a research or belief for 100 years to give him a legal shoulder to kick him out. It need an. But what I'm telling you, you do that, and I do that. And you remember that the high dose was given before, and for us were given before, and we believe that narcotics is the best drug, but really it is not the best drug if you're working in pain clinic and you see those people.
Yeah. So thank you, Dr. Yasser.
I have a comment, please, Dr. Haitham.
Yeah.
I am like Dr. Yasser. I have no any experience with cardiothoracic anesthesia, but I am with you completely, Dr. Haitham, that I can suppose or can't imagine that the patient will have cardiothoracic surgery without narcotics. So I am in your team, Dr. Hayes.
Yes, Dr. Safa. Dr. Yasser, really,
Now we are 2 against 1.
No,
لا, I'm not
actually,
against. I'm not against. You understand me in a wrong way.
Just
You
a
know,
joke,
no,
Dr.
I'm
Yasser.
not with. I'm not against.
Just-
but the
just-
era will
just
come to
funny.
tell you
Well,
that you
just
are wrong
funny,
after
Dr.
some time.
Yasser.
This is a problem.
well,
You know, we have a
are
very strong
hoping-
belief about something, and all this thing changed. You remember when we started our
Dr.
career?
Yasser.
About 90% changed, and
Yes.
we believe in that. Yeah.
Well,
Yeah,
I know
Dr. Yasser.
definitely that we are really notorious. I mean, in the cardiothoracic anesthesia in general, we are notoriously really bad about using mega doses of just of fentanyl, or like, or maybe getting the family size ampules. You know, I have this joke usually. Do you need the big one, the big fentanyl, or small one, even when I'm doing hernias or like laparoscopies and other things. But between me and you, and Dr. Safa as well, sometimes, you know, I feel that those patients, when they wake up in the ITU, or like post-operative in the back or in the cardiac ITU, I believe that those patients they develop easily a kind of tolerance that makes me thinking about opioid-free analgesia at the end. This is a surprise for everyone. Although that I was lobbying for you before the surgery, or during the surgery, or during attending the anesthetics in general, but definitely, I feel that those patients need ketorolac, non-steroidals, and it works very well. Tramadol, for instance. And it works very well with them. It works really very well with them. So, for as an analgesia, I think I'm very supportive to your perspective from my side of that story.
Yes.
That's it. Thank you.
Sometimes, Dr. Haytham, it is enough for your patient to have non-steroidal or tramadol, and they not in need for opioid in ICU post-operatively.
Yeah, it works with them very well, and the new era now is using the ketorolac along with tramadol. It works very well, actually, even for the cardiothoracic patients as well, even for the CABG and valve surgeries. And but also, I mean, you should consider the BCA is on the background as well. They keep the BCA as a background or the plan B. So in case of the need of the patient needs a backup or an umbrella for an opioid, it's there. So probably at the end of the day, we still have the opioid as a gun in our back. So in case if we need it at any point, probably it might really cover you in case of your original plan is being failed.
Yeah, or may you add narcotics to your regional technique used for the cardiothoracic, as the electrospiny, thoracic epidural, whatever the regional technique used for your patient. You may add secretly narcotics for this regional technique. So agree with me?
I haven't tried that. To be honest, I haven't tried that. Usually I go with the levobupivacaine 0.25% or almost like 30 mils in the rectal spine. I'm not sure if I haven't tried actually to add opioids to that, but maybe I agree with you. It might have a difference. I mean, make a difference, significant difference actually. It needs to be tried, but I think there is no enough evidences to do that based on my knowledge. I mean, as far as I'm aware, but I'm not sure if Dr. Yasser can support that as well or not. I mean, for how long and for how big is the additional dose of the fentanyl or like opioid could be added to the electrospiny blocks?
You mean systemic or perineural with the medication?
Adding to the local anesthetic during the electrospiny.
Yeah, the problem with that, you give a narcotic because you have another additive more bitter and more studied and have a low side effect. You can give an dexamethasone, you can give a Brisidex, you can give even magnesium. So why are you using narcotics?
Yeah,
this is the same. I don't like narcotics.
Dr. Yasser, I mean that you haven't used the narcotics as in systemic manner and use it, adding it to the original techniques in different operation, not for only cardiothoracic, maybe for the.
You mean perineural or IV?
I mean added to the local anesthetic during regional.
This is one of the option which is not a good option. Why? Because we have another more safe and more studied medication like dexamethasone, like clonidine, like Berizidex, like even magnesium have a very good thing from this era.
Yes.
So if you give that for perineural block, you get a benefit about 100 to 500 minutes more. So
Yes.
why use narcotics? The same problem. I get the same problem from narcotic, and I can just doing that with another drug. Why use narcotics?
Among our great attendee, Professor Muhammad Ahmed, and I think he will told us about the intrathecal morphine. But please, Dr. Muhammad, you will wait because Dr. Muhammad Wahba, since longer time, have a question. Dr. Muhammad Wahba, تفضل. زي حضرتك يا فندم.
اهلا بيكي، السلام عليكم.
وعليكم السلام دكتور محمد.
الحمد لله
اهلا وسهلا. اهلا وسهلا
على استمراريه الليجاسي اوف دكتور سعد مهدي. Thank you very much for the nice presentation. But I believe in when someone make a presentation, he has a hidden message he need to deliver to the team to understand his thoughts or idea. And I did not get exactly what you want. Do we need to work in the opioid-free environment, or do we need to be a little bit meticulous with the opioids to manage our pain post-operative? Number one, we are dealing with pain. We are not dealing with the opioid-free environment or opioid excess and addict post-operative. Treatment of pain is the big task. And I also believe that there are certain modalities for pain treatment. Part of it is the opioids. The other is non-steroidal anti-inflammatory. Third is regional blocks, local anesthetics, modulation response from the brain like ketamine and magnesium. All this work plus the cognitive, which I'm very happy to see your slide talking about the cognitive behavior. Depends on the culture, the religion, music, you can hear Quran, Bibles, whatever. It is the part of the modality. Now we have 5 things, and I know from the professors, I was working with them in England, that you have to achieve 3 out of 5 to get a good pain treatment. In that sense, we can get the opioid completely off the equation by having the 3 from regional blocks and steroids and the non-steroidal anti-inflammatory, magnesium or modulation like ketamine and so on. But it is the action is to treat the pain. And I am very happy to hear from Dr. Safa that fentanyl 100 mics is not a pain treatment. It is only to obtain the reflexes of the intubation for the first 90 seconds. That is excellent for all of us to understand this. So if we see someone giving fentanyl 100 mics before induction for the operation and he said this is enough for him, it is not enough. So my question is, why are we not considering the 3 points to achieve the pain treatment rather than to think about the opioid and non-opioid and things like that? I believe, my personal belief, because I'm doing the pain clinic as well in my hospital, and I believe that we know the patient when he is a drug addict to tramadol or gabapentin, things like that. This is a category of patients we don't want to talk about them, but we are not creating those patients. They are habitual use of this type of medication. That's why they end up from being treatment for pain treatment to and drug addicts. But that, let's go back to my questions, which is pain treatment, 3 out of 5. What do you think, Dr. Yasser?
If you that's that 3 out of 5 or 2 out of 5 or 4 out of 5, we need the data. We need a study about it. So I'm just saying about telling you about that there is another paradigm shift. It will be soon in the future, and we did it subconsciously because you and Dr. Safa and me and all people was using only one drug before. Now with the multimodal analgesia become a concept. Even there is a lot of don't have a very good evidence for a study because sometimes study in pain is very difficult to do. Like to send a patient with parachute and other person without parachute to see he will die or not. but this is a concept accepted by most of the anesthesia community for our understanding of pain processing. So 304 or 504 or 505, it needed data to tell us that, for example, 305, like 405, more better or less. So what we need now to decrease the pain score as possible as we can. So I agree with most of you said, but my message here, there is a paradigm shift about the narcotic-free anesthesia, but still indebatable. And I think you were thinking about it, and we do it subconsciously, because usually we use a multimodal anesthesia, we decrease the narcotic requirement all the time. And I hope one day in many cases, but as I said, there is a contraindication to use a narcotic-free anesthesia. Still, this category of patient, I don't know the percentage, 20%, 30%, but in many patients, as what we did in our hospital now. In our hospital, we have a regional anesthesia program, we have a pain program. So most of the people coming to recovery, I'm head of recovery. About at least 60%, I don't give him narcotics. And this is a very good achievement, because we started to give everyone narcotics, and now 60%. It may be paradigm shift at the future. It will be 80%, 90%. And whatever you use to help the patient is a very good concept about multimodal analgesia, preventive, pre-emptive analgesia is a good concept, but I just try to show that there is another paradigm. It started in Australia and using the narcotic-free anesthesia, especially in bariatric surgery. And I use the monitor all the time, and it works very good. And we do that in many patients here in our hospital. But to reach 100%, you know, as I told you, there is no gray and what's called black and white. We have a gray zone all the time.
دكتور محمد، شكرا لحضرتك دكتور محمد وهبه. دكتور محمد احمد. دكتور محمد اتفضل حضرتك.
السلام عليكم دكتور.
وعليكم السلام دكتور محمد.
ازي حضرتك؟
الله يكرمك يا فندم. الله يبارك فيك دكتور محمد.
Thank you very much Dr. Safa and Dr. Yasser for allowing us to enjoy this very informative presentation of Dr. Yasser.
حضرتك منور يا دكتور محمد. شكرا لحضرتك على كل حاجه.
الله يخليك.
Egyptian Society of Anesthesiology and Acute Care, thank you for everything you do for our society.
الله يخليك.
Your endless support. Thank you.
الله يخليك. I think there is another expression which is opioid sparing anesthesia, which is more commonly used than the opioid free. Most of us nowadays are practicing the opioid sparing anesthesia. I'm practicing this opioid sparing anesthesia in all patients. I use all the other non-opioid multimodal analgesia techniques, and then I keep the opioid as the last option intraoperatively, and use it as PRN when indicated only, or when I feel that the patient is in need for more analgesia. At the end of surgery, it ends either I didn't use any opioid, or if I use opioids, I use very small doses compared to that what I was giving 5 years ago. I think also we are generous in using opioids, because we had false concept or false belief that if we are giving opioid to treat pain, patient will not be addictive to this opioid, and this is completely wrong. And it was propagated by the companies that wants to sell more opioids. So there was no evidence that if you will give patient opioid to treat pain, patient will not be addictive. Although the opioid crisis which happened in USA was the motive for them to use the opioid sparing analgesia, but I think our generation and those who were older generation than us, they tried the opioid-free analgesia, because when we started to practice anesthesia in Egypt, most of the private sectors, they had no opioids. So we are giving all other measures to give adequate or near adequate analgesia for these patients, because we don't have the opioids at that time. I don't think that we are at a risk of opioid crisis in our communities like USA, because in USA they give the patient after very minor surgeries, they give him a prescription for morphine to be used for 3 months, and patient can refill for another 3 months. I have one of my relatives who did double J insertion, and they prescribed oral morphine tablets for 3 months. And this patient was able to refill for another 3 months after only double J insertion. So the presence of opioids in front of the patient and in front of the other family members at home, the availability of these opioids, it encourages those people to try these opioids. And then this is a door which will lead to the addiction. Very, very great presentation, Dr. Yasser. It deals with the concepts of practice. So we have an ethical rule in controlling addiction due to opioids that may occur after the patient receives large doses of opioids in the perioperative period. Thank you, Dr. Yasser, and thank you, Dr. Safa.
Thank you, Dr.
I have a comment on your, Dr. Muhammad. The problem, you said that we don't have such a problem in our country. Really, we don't have a statistics. This is a problem. But if you look for the statistics, because we have now as a system all over the country for Qatar, the system, and we can count those people thousands.
Yeah.
But if you don't have a real statistics, America have a real statistic. So you feel this no problem, but really, you know, under this fire is the ash. You know, you have a lot of patients, many addicts. As I told you, as someone killed, I want to stab his mom, dad, and his brother because he need the money for the drug. And we have now tried to collect the data about those people who found thousands in a small country. You know, this is a problem. You know.
Just I have a comment, please, after you, Dr. Yasser and Dr. Muhammad. Of course, the drug dependency syndrome or addiction is for some people speaking about genetic predisposition and the presence of psychological troubles, depression, etc. Also for the patient who are on chronic disease and receiving for many times all the types of analgesics, and they upstroke to the narcotic analgesic, and as Prof. Muhammad said that they use high dose for a long time. So the surgeon by themselves prescribes the narcotic after the operation, and so this is one of the problem why they have upstroke in addict personnel in USA.
Yes.
I think the surgeon not write a prescription, like, because we have an American system here. The surgeon not supposed to write any medications. There is acute pain surface control the patient.
You know, Dr. Yasser, that I have prepared the pain management in drug dependency syndrome, and I write this exactly. I write it in the paper.
Surgeon writing?
Surgeon, yeah.
Because here we have like an American system in Qatar. The surgeon not writing, and even if want to discharge the patient to give a medication, he speak to you.
And as Dr. Muhammad said, this terms sort of patient satisfaction, او يعني هم عندهم حته زينا ساعات لما بندلع العيان شويه. هو السيرجن
but you know that within few days from 30th of June it will be attested he can't do anything like this because of the crisis. And just I write this within few days. No one can write except after that revise and attest it because of that. I think
you know that I prepared this presentation and I have it already. We have a question from Muhammad Ali asking about your experience in having narcotic-free or opioid-free anesthesia in bariatric surgery.
We have a problem here in Qatar because the bariatric team is another team not belong to anesthesia department. Just the working with us, but this team about 4 persons about anesthesia. But unfortunately, he don't make an opioid-free anesthesia. And most of the patients come to recovery screaming. You give him 10 milligram morphine. he gets in obstructive sleep apnea. You give him oxygen. Sometimes you intubate again because of all patients is very obese. And you know, my experience I was doing in Saudi when I make this case, just most of the time we give him multimodal analgesia, narcotic less, because we know that, you know, what happened in recovery. But in our team here, we don't have a bariatric section, it's a different section. And usually I don't make anesthesia for bariatric, but I see all the problems for people coming to recovery and take narcotics because sometimes the physician which brings the patient make a post-operative plan, and most of the patient get an spiral depression and hypercarbia, many things there. Snoring was like a baby elephant, you know.
We have a question from Barry Fredberg. Okay, Dr. Barry, are you here? Dr. Barry. Yes, he gave a comment here that 1,000 milligram acetaminophen with 800 milligram ibuprofen 4 times per day was very efficient for his pain management after hip replacement surgery.
Yes.
This is Dr. Barry Fredberg. I know that you know him, Dr. Yes.
Yeah, but it's okay. It can be happen because it's different response for different medication. But if you don't make a block is the best for him. But if you don't make a block or someone not experienced with block, and I give paracetamol, whatever, non-steroidal inflammatory, still have a pain, you can give narcotics, but it will be a very little amount because the response of pain different from 1 to 1.
Also, he sent the other message, 50 milligram ketamine plus propofol sedation dose provided 10 to 20 minutes will add more for the patient.
This is a part of multimodal analgesia. You use your regimen, make your protocols according to resources and the community. It works. But whenever you give a narcotic alone, it can give a high dose and you have all the sequelae of narcotics. But at least, as I said, if you can't make it narcotic-free anesthesia in this era, it is at least narcotic-less anesthesia, narcotic-less era to less and less for narcotics.
Yes. Anyone from the floor have another? Dr. Muhammad Wahba, you still have a question? You still have?
I have a comment actually regarding the bariatric surgery and the post-operative pain treatment.
Yeah.
This is personal experience because actually I did around 102 cases yearly for a giant elephant زي ما الدكتور ياسر بيقول, and most of them are with obstructive sleep apnea plus comorbidities. I do the multimodal analgesia for the patients, and none of them need to be admitted in ICU post-operative or re-intubated. Maybe because I have a good surgeon working with me, maybe I do multimodal analgesia for them. And as I always use the 3 out of 5, and I exclude the opioids completely. I use ketamine, I use the non-steroidal anti-inflammatory regional block, especially in the port when they're going to take the stomach for the gastric sleeve procedure from it. This will, you can get away without any problems. In the recovery, patient in the semi-sitting positions, good oxygenations, everything will be fine. My experience is you don't need much of opioids for those kind of elephants, as you said, for post-operative in the recovery. What's your experience?
Yes. Thank you, Dr.
And one more thing, also great that we have your slides about the USA and the use of opioids like over the shelf. This is really an exciting situation. That's why the American Heart Association and the CPR committee made the new updates for the year 2020 that tell you when you have a patient with cardiac arrest, always think of naloxone or Narcan as one of the immediate medication for resuscitation, presumably that those patients are overdosed narcotics. That's why in the new guidelines for the CPR, for the ACLS guidelines 2020, always putting in consideration Narcan as one of the medications to be used for resuscitation. Thank you very much. Thank you, Dr.
Thank you.
Safa, for all the effort
Thank you,
you are
Dr.
doing.
Thank you.
Thank you,
And
Dr. Yasser,
we
for
are
your
waiting for
Thank you,
presentation.
Dr. Wahba. Thank you very much for coming.
We are waiting for you, Dr. Mohammed Wahba, when you have your plenty of time to have a presentation here for Isaac. Thank you.
Inshallah. Inshallah. Thank you so much.
Thank you, Dr. Wahba.
Inshallah. Thank you, Dr. Haitham Al-Jamil, for your nice work. Very, very, very nice work. You always encourage us. You always supporting us endlessly. Dr. Hani Bayoumi, thank you.
It's always
Thank
a pleasure,
you.
Dr. Safa. Always a pleasure to be with you, and also a pleasure actually to see Dr. Yasser. Usually, it's a very joyful moments to get along with this good gathering. So it's a pleasure and it's a great honor for me as well to be contributing with your session. Thank you so much for everything, for the selection and for the participation.
Thank you. Thank you,
Dr. Safa, I think there is two questions more. I think one question is.
This is from Pari also.
The chat box. There is a question here about.
This is the Pari also. I don't. He has a comment also. I don't know how to get his question.
I think there is also a question from someone here.
Dr. Samir. Dr. Samir. Dr. Samir, do you have a question?
أيوة دكتورة صفاء السلام عليكم.
تفضل وعليكم السلام ورحمة الله وبركاته.
I have no question. I'm just thanking you and Dr. Yasser for this lecture. Amazing discussion, actually. But in between this battle, I think all of us are doing now the sparing of narcotics during our practice. And the era of studying a lot of other drugs, like at last ketamine and magnesium. In neurosurgery, we did it for the Mayfield clamp application for the to attenuate the vasopressor effects in such circumstances. I think we should follow the rule: less is more. The same principle. Always use a multimodal. As regarding the pain, we learned from our professors that the biopsychosocial model was the best to deal with the pain. This is why Dr. Mohammed enhanced the speech of Dr. Yasser about the cognitive and behavioral aspects of the patient. You should tailor your practice for every patient. You should see some patients we saw not the same level or threshold of pain. This is because their background, either religious, culture, or whatever. The difference, the genetic one, is the most important one. Dr. Yasser spoke about in Saudi Arabia, people were more sensitive. Yes, this is because about 30% of the people in Ethiopia, especially, and Saudi Arabia, are descent have heightened CYP2D6 gene, which is the gene for the enzyme, which means that they are ultra rapid inducers for the codeine and tramadol. These differences should be considered when dealing with such patients. Pain treatment is a very complicated subject. A lot of things are conflicting this. I think the balanced regimens we started to use in the last 2 decades is very useful. Is very useful in this. To omit completely the usage of opioids is not capable. We cannot do it nowadays, even with the nerve blocks. Actually, most of us now, when you do cesarean section after spinal analgesia, it's now opioid-free anesthesia. But to omit completely from our practice, it will be difficult even in the future. This is what I think, but we need always to balance and to weigh this the effect we need from the drug to the side effect we may expect. This is my only comment, and thank you, Dr. Yasser, Dr. Safa, and all, Dr. Muhammad, Dr. Haytham, everyone. It was a very amazing discussion, actually. Thank you. Thank you.
Samir, thank you for supporting Isaac. Thank you. And thank
Dr.
you.
Safa, I think there is two questions here. Someone,
From
I was
Karim.
recovered.
Karim asked you, Karim Mekhimer asked you that if the BCA is going to have some role in addiction.
Unfortunately, yes.
Yeah.
We think that will give a small dose and patient control has been, but many patients started and continued. BCA is the same like a narcotics.
Yes.
You know, you play in the what's called therapeutic zone, but still it can. You see here, I see someone WSI4. I was recovered.
Dr. Mahmoud Ata asking about the convenience of the surgeons, that it is how to convince the surgeon that it is better doing regional block rather than GA and safe opioid use in young healthy man, medically free.
You know that this question, I came here in Qatar, and you know that what I found here, about less than 10% of the surgeon can accept a block. Now about 95% can accept a block. What we do here, it's very, very difficult to convince a surgeon except if he's a patient. I have one of the orthopedician. He going as a patient. He never accept a block until he going to make and have a cruciate ligament and make an operation. And you know that they don't tell people about the block. And I found him screaming in the recovery. And he tell me, ask me, if they give me morphine, I feel drowsy and nauseating, but I feel the same pain. So I give him a ductal canal block. You can't imagine, within 15 minutes, I just going to see him, he kissed my hand. Until me, I never rejecting block again. But you can't make that with every surgeon. The surgeon need a trust, need to use his time. So what we do here, we make a block room before to block the patient, to test the patient, because some of the surgeons said they're waiting for 45 minutes or 50 minutes, and at the end I found 50% of the block not working. Yes. Now there is a program, and most of the people here, the fellows or residents, come with me in the recovery. You bring a patient early, someone in the recovery, bring a patient early, we make a block, we test our block, we give a supplementation if we need, we give a sedation if we need, and send the patient ready. And because of that, most of the surgeons said, make a block, because he don't wait for general anesthesia to start. The patient come anesthetize. Because usually the surgeon underestimate two things, the bleeding and the time. You know, he can, for example, leave the junior staff to close the wound in 2 hours. Yes. But he look for your 5 minutes as 5 hours. So how to avoid that? To assign one of the surgeon, was a scientific one, to make a preparation before, don't let him to wait. You know, you can make a block in another room to be ready. You test your block because the failure rate will be less. This is what we did here, but I don't know the situation with you. You can do it right. Yes. And now most of the surgeon accepting to be and to make a block. He don't have any problem. Even sometimes some of him asking for block, you know. Yes. Yeah. So I think here to someone, right? I was recovered with blood pressure. There's a anesthesia and there's a patient. You see this one? Yeah. Yeah, I don't know who is. I don't know, but she's a doctor and she is under operation, major surgery maybe. The doctor and patient at the same time. What? Yeah. The doctor and the patient at the same time. Yeah. And from her severe pain, she had this reading of blood pressure, and her doctors were confused how to treat her pain and her suffering. Yes. And the postoperative? Yeah, yeah. She was just said the plan, put it before the public assessment. The plan of analgesia must be put in and discussed, not post-operative, because if the patient feel a severe pain and you give him a medication until you bring morphine or any drug, it takes about 20 minutes. to be prepared to give it. So it's not a quality.
If she is present still with us, you can ask your question by yourself. Yeah. Someone asking you about the comparison between tap block after cesarean section.
Tap block is one of choice, ilioinguinal hypogastric. You know, tap block is high volume block, facial balloon block, and ilioinguinal hypogastric is a low volume tap block also. It's the same block, but the other one you make an floating. And I have a paper I published is 2008, when starting the era of regional anesthesia. We make it for obstetric. We found that the tap block is more convenient, less pain than the ilioinguinal hypogastric. So it is a good option because balloon block, if you inject it, for example, levobuprofen or bupropion, it can stay from 16 hours until 3 days or 2 days. So a very good option, and avoiding the narcotics.
Yes, we have a comment here also from Barry. He said that regional anesthesia is great, but does not block all cutaneous cortical input. And as you know, post-operative pain is a function of intraoperative.
Yeah, I agree with him. But regional anesthesia helping a lot, you know. And our patient, most of the obstetric patient, orthopedic spine, just get a block and the patient discharged completely. And we don't wait for example, if you make a regional anesthesia, spinal for TKR or anything, I don't wait until the patient get a pain to give him analgesia. It's not a quality. Yes. So I just start when he come back, still anesthetized still, I just give him a ductal canal block. Most of the patient can see 2 days.
Yes.
1 to 2 days from analgesia, you know.
Yes. Anyone have a question from the floor, please? Anyone have a question or comment? If I forget anyone, if I forget the question of anyone, I mean, all is good. Yes. Yes, we have no question.
Yeah.
Thank you, Dr. Yasser, for your time. Thank you for your time and your endless support. Thank you for everything. Thank you for being with us today. Thank you, Dr. Yasser.
Thank you, thank you for everyone, and sorry for delay.
Thank you.
Thank you.
The next Saturday we have Professor Dr. Ahmed Abdelrazek Osman. He is Professor of Critical Care from Saudi. He is an Egyptian, but work in Saudi Arabia. Will have the topic. His topic is cardiogenic shock. Inshallah. شكرا لحضرتك يا دكتور ياسر. شكرا جزيلا. شكرا جزيلا دكتور هيثم، دكتور سمير، دكتور محمد وهبه، دكتور محمد احمد. شكرا لكم جميعا من غير ترتيب، كلكم على راسي من فوق. شكرا جزيلا. السلام عليكم ورحمه الله وبركاته. شكرا جزيلا.